Good afternoon. I'm Mary McGowan, Executive Director of the Myositis Association. I want to thank you for joining this afternoon's leadership webinar. We are most excited to begin this webinar with an opportunity for a sit-down question and answer session between Dave Mokel, Vice Chair of TMA's Governing Board of Directors and person living with inclusion body myositis, and Dr. Rohit Agarwal, Chair of TMA's Medical Advisory Board. During this one-on-one interview, Dr. Agarwal will be answering questions posed by you, our TMA members, about COVID-19 and myositis in general. If you have questions throughout this discussion, please type them into the chat box, which is located at either the top or the bottom of your screen. In order to optimize the time we have with Dr. Agarwal, let me pass the microphone over to Dave Mokel. Thanks, Dave, so much for being with us here today and for conducting this very exciting interview.
Thank you, Mary. First of all, I'd like to welcome everyone to this webinar. And understandably, we will be spending a fair amount of time talking about COVID and the common questions that many myositis patients have. We will get to some non-COVID questions as well. Please feel free to use the chat feature that Mary just described, and whenever possible, I will try to address those questions. My attention span is somewhat limited, so I will be bouncing back and forth, so if I don't get to your question, don't take it personally. The questions I will be asking Dr. Agarwal come directly from you. We have received a lot of questions from patients and caregivers who responded when registering for today's webinar, and we thank you for doing that. We also have a number of overflow questions from a recent webinar on environmental issues and autoimmune diseases, in addition to our joint webinar with AARDA on the current CDC recommendations for COVID-19. Dr. Agarwal is a panelist on multiple webinars within TMA and elsewhere, and we are very fortunate to have him with us today. So thank you, Dr. Agarwal, for joining us today. First of all, congratulations on being named the new chairman of the TMA Medical Advisory Board. If you could briefly explain how the Medical Advisory Board works with TMA, and then specifically, what are your goals for the coming year?
Sure. The Medical Advisory Board basically is a very interdisciplinary board. There are several members from rheumatology community, dermatology, neurology, and physical medicine and rehab community. These are all the experts in the country, and in fact, international experts are included in this as well, who actually day in and day out work on this disease, whether in terms of taking care of patients and providing their opinion, or in terms of research. And the way the MAB, the Medical Advisory Board, work with TMA essentially is provide guidance to the TMA on all the topics that are related to any kind of medical questions that the patient may have or research associated with myositis.
Sounds great. And in particular, are you looking for anything to accomplish this year, any specific goals?
So I have some personal goals. Since I became the chair of MAB, I want to promote this year patient information, education, as well as significant advancement in understanding of myositis. I feel oftentimes when I'm seeing patients, they are at disadvantage because there's a lot of information for various of the disease online and otherwise, but very limited information on myositis available. So what I want to do is increase the amount of education available to our patients to understand their disease, because if they understand their disease better, that will help us managing their disease better. So we have various videos that I post on YouTube, which are shared on the myositis website as well. Also, we are doing several webinars like this and other educational seminars to promote the patient education and understanding.
Sounds great, and thank you. As someone with IBM and myositis, it's important. It's hard to get, I was diagnosed in 2013, so it's a lot better, I would say, than it was in 2013, but getting that good information is challenging. And I have the advantage of being a physician, so I somewhat know where to look. So I think we'll be able to, hopefully be able to help our patients. So as Mary said in the introduction, I do have IBM, and certainly I'm concerned about COVID-19. So I guess my question for you is, could you speak to how COVID-19 could affect different types of patients with myositis, and are there, second part of that, I say, are there certain myositis patients who are at higher risk of catching COVID? Two parts.
Yeah, sure. So first of all, we need to understand all myositis patients are at increased risk for all type of infection. And when I talk about all type of infection, obviously currently COVID-19 is the most infectious agent that we are dealing with. So obviously COVID-19 are all myositis patients are at increased risk. They are at increased risk for various different reasons though, because there are different types of myositis. So we need to understand what are the different reasons. Typically, our myositis patient, other than inclusion body myositis, are at increased risk because they may be on immune suppressive medications. These medicines suppress the immune system, weakening their ability to fight viruses and bacteria and other infections. So is in the case with COVID-19. Another reason is many of our patients have difficulty breathing because they have interstitial lung disease, or they may have a respiratory muscle weakness. And that, since this virus can affect the lung system very easily, it's a respiratory virus that also poses a secondary increased risk for our myositis patients. In talking about IBM in particularly, many patients with IBM may not be having immune suppression or interstitial lung disease, but they are also at significant higher risk for COVID-19 or other related infection. First of all, we know most of the infections, including COVID-19, affects more patients in the ages of group of 50, 60, and 70 years. And that's where the IBM is more prevalent. We see IBM mostly in patients with above 50 or 60 years of age. The second reason is that IBM patients often have difficulty in swallowing. They have dysphagia. So what they do is sometimes they aspirate in their lung, causing injury to their lung. And given this virus is a respiratory virus, it can easily infect lung in these patients and cause significant problems for these patients. So those are various reasons, but the reasons might be different for different types of myositis, but definitely myositis in general is a very high risk for COVID-19. And I would appeal to all my patients to stay home as much as possible.
Sounds great. Thank you. So let's say someone with IBM or myositis in general was diagnosed with COVID. Okay, let's say with, unfortunately, probably will happen to a subset of our patients. The good news is in general, at least in Chicago, which is where I work, 80% of the patients diagnosed with COVID are able to not be treated at home, which is a great sign. But I think if they are, let's say it was myositis in general and maybe even IBM, probably you can lump them all the same. If they were diagnosed with COVID, aside from the normal medical recovery, one thing that I thought about was rehabilitation. Like at some point, if they, could you speak to, if you are unlucky and are diagnosed with COVID, and hopefully you will make a simple, easy recovery or be asymptomatic. Let's say that you do get it. What are things that you need to pay attention to, obviously, if you're at home?
Okay. So first of all, having a COVID-19 infection to a patient who's already weak, for example, IBM or PM or DM, other patient who are already weak, would be like getting another second hit to their body and the muscle. So definitely they're going to be significantly affected if they get COVID-19. The other problem is the rehabilitation going to be more difficult for these patients. One, because they don't have any place to go to for any kind of therapy. Second, at home, the rehabilitation could be very limited. The third, they actually may not have enough energy to actually do any kind of recovery or rehabilitation after getting an infection. So though for all those reasons, I think it's it's going to be big problem for patients who develop COVID-19 while they're having their IBM or other myositis being active. The fortunate part in this is most COVID-19 infections are actually mild infection. So I'm hoping even if our patients get infected, they remain in the more milder stage and not get into more moderate or severe stage, because that will be very difficult for our patients to recover from.
Sounds great. Well, I think that's what it brought my, when I was watching the news like everybody else, and I was seeing these guys who were marathon runners, 2 months ago, and all of a sudden they got hospitalized with COVID. A lot of them ended up on ventilators, but some didn't. And then they showed them at home, and they're struggling to do sit to stand exercises. They're struggling with a walker, and I'm thinking, man, that's me on a good day. So I think that's what prompted me to consider this question. So I think
so let me add on to that. I just recently saw a case report of COVID-19 leading to actual myositis, muscle inflammation. Patient did not have a myositis diagnosis before, but got COVID-19, and when the patient was sick, their CK levels were more than 10,000. They had significant muscle weakness. Now it's unclear whether they got myositis concomitantly or COVID-19 actually led to the flare-up of myositis. That's a little unclear. But what happens in general, any viral infection, patient's muscle always gets affected. That's why you get muscle pain and fatigue when you get any kind of viral infection. Even with flu, it feels like I have a myositis when I get a flu because my muscles are aching. I don't have much energy to do anything. I'm fatigued. So if you're already weak and then you get this, obviously, as you were saying, it's going to be very difficult for our patients. So the better thing is to keep protection as your main tool to, to fight against COVID-19. And the three things to remember is hand washing, social distancing, and masking as much as you can.
Sounds great. Well, to follow up on that, I would say the hand washing and the masking are maybe a little bit easier. The social, at least we're starting to be able to get supplies now, which is a good sign. The social distancing is interesting. I'm kind of in the moderate category, I would think, if there is such a mild, moderate, severe of IBM. To be honest with you, my world is small. So everybody's complaining about they can't do this, they can't do that. My world is going from here to the kitchen, limited trips outside on a good day. So to some degree, a lot of people, I think in a moderate category, I'd say with IBM, already kind of do this to some degree anyway. So as far as patients, what should we be looking for? Okay, so I think for all the reasons you just mentioned, we've got to try to prevent it if at all possible. So when you talk about social distancing, what is it we're looking for? Is it a vaccine, which is going to be a way? Is it certain therapeutic? Is it antibody testing? Obviously, vaccine is the easy one, but that's probably going to be a way off. So what are the cues? And this is probably somewhat regional. If you're in a very rural area, it may not be an issue as opposed to if you're in downtown, Manhattan. So what are the things that myositis patients in general should be looking for before they relax their can relax their social distancing?
So typically, any kind of pandemic like this, once you have about 40%, 40 to 60% is the number that is generally given. About 40 to 60% of your population or your community or your city is infected, then the risk of virus spreading goes down significantly. So what my take on it is, people who are at high risk, especially elderly patients or patients with myositis and other comorbid conditions, needs to be protected until we reach a stage where the population in general is about 40 to 50% of them are immune or has been infected. That's the goal. And then only we can really relax the social distancing norm. When that's going to happen is very difficult. That may take months to almost to the end of the year to happen. But we are hoping that by that time there are effective drugs and vaccines available. If vaccine is available, that will be really good, because then all the community and the city could be vaccinated, and people with comorbid conditions can come out and can face this easily, and then social distancing will go away. But it's difficult to say. I think the social distancing, from my standpoint, is there to stay for at least months, if not till end of the year.
Okay. Well, thank you. A couple of questions have popped up. One, I'm going to get to about just talking about managing IBM myositis when there's no treatment. We do that maybe after the COVID. But another one I would expand on it. There's a question about an antisynthetase syndrome patient, let's say, who presents. I would maybe expand this, Dr. Agarwal, to anybody with interstitial lung disease. Okay, let's say it's anybody with interstitial lung disease. Let's say you show up, you get it, and you go, is there any specific treatment at this point? The question also talked about chances of survival. I think that one's going to be a tough one to answer, but I would say probably the more pertinent one, or the meaningful one, treatment. Is there anything specific as far as treatment? I can speak to what they're doing at Northwestern now in protocols, but at the end of the day, how about you? Is there any specific that would be unique to a myositis patient with ILD or an antisynthetase syndrome patient?
So, patients with antisynthetase who obviously most of them have interstitial lung disease are at a major risk, because it's a respiratory virus, it's going to affect your respiratory system. And given that you already have a compromised respiratory system, this is going to be very difficult for those patients to recover. So my take on it is prevention is the best cure. In terms of treatment, and there are a lot of encouraging reports. Unfortunately, none of those reports are confirmed. In other words, they're not been confirmed by the best scientific evidence of a randomized controlled trial. We have various antiviral drugs that are currently in trial and have been used clinically as well. We have also people who've been treated with steroid. Many of them have shown recovery. The patient with treatment with plasma has been very effective in various centers, but it is difficult to say whether those treatments are going to hold true when we actually go through a randomized controlled trial. We heard about hydroxychloroquine being effective initially, and now many negative studies are coming out. Again, it's very premature to say that this drug works or that drug works unless we have a good randomized controlled trial that can answer that question clearly.
And I think compared to other diseases, the sharing of information, I think as far as treatments has been substantially greater, to be honest with you, for obvious needs. So the good news is, unfortunately, a lot of these treatments are getting out and they may not be, studied appropriately, as you said. But the good news is, I would say there's fairly widespread sharing of protocols, treatment protocols and the like. So I think the good news is people are all wanting the same thing. I think as far as getting onto the hydroxychloroquine, like you just mentioned, there's been a lot of discussion about chloroquine and hydroxychloroquine. Is it safe for a myositis patient, let's say, to take this medication if it was prescribed for he or she?
So before I tackle the safety question, I want to tackle the efficacy question, which basically means, is it effective? So first of all, initially we had a lot of basic science and 2 or 3 studies, not well designed, but limited studies that came out that showed it was a positive drug. And that led to popularly people assume automatically this is a drug that's going to save everybody. That wasn't the case. And then subsequently, we have more studies coming out. Almost all of those subsequent studies are coming out to be negative. Again, even those negative studies, as the case was in positive studies, are not well-designed good studies, which means the scientific evidence would be modest at maximum. So I would say currently we don't have a clear evidence whether hydroxychloroquine or chloroquine works in COVID-19 or not. And we have to wait for a randomized controlled trial. Good news is there are some randomized controlled trial on this topic, which may inform us within next coming weeks that whether it's good or not. The other part of it is it safe? So the safety really comes, is it effective? If it's not effective, no drug is safe, But if it's effective, if hydroxychloroquine is effective, then it's a very safe drug in general. Now, there are some caveats to it. There are 2 issues that comes up when you take hydroxychloroquine. One is the issue of QT prolongation, which is an abnormal rhythm in our heart. So generally, hydroxychloroquine, we haven't seen the QT prolongation on its own. It typically happens when you're taking another drug that can prolong QT, for example, azithromycin or other drugs that you might be taking. This QT prolongation issue or heart issue is more associated with chloroquine, which we don't use that often. The second issue with hydroxychloroquine is basically some patients, very rarely, hydroxychloroquine actually can cause myopathy. Very few people know about that because it's so rare that in my last 10 years, I may have seen 2 cases of hydroxychloroquine causing myopathy. Now, when patients already have myositis, they don't want to develop another, they don't want to take another drug that can cause myopathy, but it is very rare overall. And typically it happens when you take hydroxychloroquine for years, 5 to 10 years. Whereas here we're talking about taking it for a few days or few weeks at max while you're getting treatment with COVID-19. So in terms of safety profile, chloroquine definitely has some problems, more problems with QT and heart problems. Hydroxychloroquine far safer than chloroquine, could have effect on muscle, but very rare, and that can be monitored. But the bigger issue is, why do I take a drug if I don't even know they're effective or not? So the main thing is the drug effective? If the drug is effective, then yes, it can be taken safely by a myositis patient with some precautions.
Sounds good. And just a question about risk factors, good question. Is age itself, we hear about age over, 60, let's say, but I mean, that's very different ages, but is age itself in isolation a significant risk factor for bad outcomes, or is it because people that are older tend to have more other medical problems? as they age?
I think that's an excellent question, and it's tough for me to say because it's not been formally studied that way. Because of most people who are elderly age group also have other comorbidities, so it's difficult to separate the two things out. But I would say one more thing, that even age alone is actually an immune suppressant. Means our immune system is not as robust when we are 60s and 70s and 80s as compared to when we are in 20s and 30s. So age itself, to me, is a risk factor regardless of other comorbid conditions, at least in theory, based on the immune system that I know about aging. But it could be that in this case, it's only the comorbidities that you're accumulating, but likely not.
Okay, thank you. Another question about the immunosuppressants. Let's say you are on somebody for various, you're a myositis patient. We could focus on that. You could expand to your other rheumatologic patients if you like. But I say that, there are we do get a number of questions about whether people should continue biologics like Humira or Cellcept, let's say if they're on their prednisone even, that's a little less controversial. But in general, let's say you're a myositis patient, maybe some of the PM or DM or antisynthetase, something that is on immunosuppressants. Obviously, you're not going to be able to give a generic, a specific answer for each patient, but what are the principles that I guess that you would look at when you approach your patients?
So when they're on immune suppressive, so let me try to understand your question. Are you trying to ask that when they're on immune suppressive drug and they get COVID-19?
No, before.
No.
Like right now. So
oh,
let's
right
say
now. Okay.
Right,
So,
right now.
So currently, you don't need to alter any of your treatment, any of your immune suppression. I have many patients, by the way, who flared up because they got too worried and they stopped their medication. And sure enough, days to weeks to months later, they flared up and they are actually now on more immune suppression than they were before because of the flare up. So my plea to everybody is please do not stop your immune suppression for the fear of COVID-19. Do common sense things, protect yourself as much as you can. We talked about 3 key things that can prevent COVID-19 infection, but please do not lower your immune suppression. The only cases where I have personally recommended them to decrease the immune suppression were the cases where we were already having discussion to decrease the immune suppression because they were doing excellent for a year or two. And that led to decrease in immune suppression a little bit, maybe few months in advance when the COVID-19 thing came up. But generally speaking, do not decrease your immune suppression without talking to your doctor.
Well, and it's interesting, in orthopedics, I did hip and knee replacements for years. And when I first started in the early 90s, that was it. We were taking everybody off their immunosuppressants to do their surgery for the fear of infection. They would get their surgery. And at the end of the day, they would flare. They would have other issues. We ended up putting them back on high dose steroids, other things. We made it worse. And at the end of the day, so as time went by, gradually the recommendations, slowed. And what we find now is, in general, for most things and most patients, we keep them on them. They sail through. They do better. So it's not analogous, but it may be. But we found the same thing in total joint. So I think that's good advice. I would say, so next we bump on to testing. I think as far as testing, actually, I'll do one more med question first. Supplies for IVIG and subcutaneous IG infusions. Have you had any supplies? Do you have any issues with supplies?
So first of all, I wanted to make sure everybody understand immunoglobulin are very difficult drug to make, because it's dependent on the volunteers to give their blood or plasma for donation, and then that leads to purification process, and then it gets made. So far, fortunately, I have not seen any major shortage of IVIG or sub-QIG, at least in my patients. I've not heard that so far. That could be that the stockpile was good, but I'm worried that in next coming weeks to months, this may become a problem because of lockdown. Patients are not able to donate. Plasma centers are stopped, they're not functioning. So because of lack of donation, and obviously because of the lockdown, we may actually see some shortage in next coming weeks to months. I hope not, but that's my fear. But so far I've not seen any. That companies tell me that they have good stockpile for months. So hopefully we'll get over this, and then the plasma donation will start again, and then we might not have a problem. But I do worry about that in next coming weeks to months.
Thank you. And before I jump onto the testing, which will be the next thing, I would say this, I get several questions about various medications, treatments, and some individual specific situations. In general, you know, stay on your immunosuppressants. God forbid you end up having to be treated. Mention it, let the people take care of you. You can ask about the different, you know, the plasma, the remdesivir, the other options that are out there. But I think going into the specifics of all those at this time is probably a topic for another day. You know, at the end of the day,
next month might be a better idea.
Yes. So next, so I think as far as testing, big question. So I think as far as testing has been seen to be slow, you know, I'm not going to, you know, rolling out in this country. So I guess people, obviously the different types of tests are, you know, the pure COVID tests are more available now. They're not all, even at downtown Chicago, we had a lot of problems learning how accurate some of the tests were, what clinical setting to use the tests, and also serology or antibody tests. So if you could speak to your advice as far as testing for current testing with COVID, no COVID, and serology.
So Dave, you understand there are two types of testing. One, you're testing if the patient currently have an infection or not, which is the, you know, RT-PCR testing, which is the gold standard testing. Another type of testing is an autoantibody testing. So I want to make sure the patient understand when we are testing for autoantibody, it's not so much to see if you have COVID-19 currently or not. It's more to see, are you immune to COVID-19? Were you exposed to COVID-19 in past? As we know, 25 to 50% of COVID-19 patients are asymptomatic. So when you're doing a testing, you're really saying, was I in an asymptomatic phase and I passed? So then I'm not at the risk of developing COVID-19 again. And that's why these two different testing. My recommendation right now, obviously, is to not to go for COVID-19 RT-PCR, the main gold standard testing, if you don't have infection. If you're not feeling sick, if you don't have cough, fever, or shortness of breath, there is really no need for testing. Should all patients get tested for autoantibody, the other COVID-19 test, the antibody test? That's a debatable matter. My personal bias is yes, that patients should get tested for it. More and more population community should get tested for it, because more information we have, better ability we have to prepare for what we need to do. So for example, if in a community we find out that, look, 50% of patients are already immune to this, then you can relax some of the social distancing and other norms, because that you've reached that threshold where 50% of the population is technically immune. But other population where we see, no, only 5% of population has autoantibody, then you really aggressively need to pursue those strategies to prevent the infection. So information is never bad, it helps. But sometimes people misunderstand the information, which makes it worse. So as long as you have an understanding what type of testing you're going for and what's the purpose of this testing, testing would be good.
Sounds good. Along those lines, well, a little bit, at least for what it's worth, I think sometimes there's a lag between what you see on TV and in reality. That's what we're finding. Like in Chicago, for example, I would say that the antibody testing really will not probably be rolling out till, you know, mid-May. Okay, meaning where it's widely available. So you can hear that it's available at a Quest or something like that. But that's usually reference lab. There's a limited number that gets sent out. It's not widespread. So you know, it just kind of depends on where you live. But I think once you may find the same thing.
Yeah, I mean, exactly. I mean, about 2 weeks ago, I actually tried to order antibody testing on a patient I wasn't able to get. And today I ordered it and I was told that it's available at Quest, you know, walk in, no problems. So again, things changes and it's regional and geographical differences will be there.
Well, and I would point out also, I think that we're going to learn a lot about this after the fact. Okay, there's a lot of things, you know, there's a reason vaccines take 12 months to 18 months in a good case. You know, it can't just be compressed to 4. There's a reason that these tests take time to roll out. They have to be validated. Yes, we're compressing the time frame, but don't kid yourself. We are still learning. We're still learning about this. And there's going to be things that we think are correct now that we will learn at some point, you know, will be otherwise, or that will be proven otherwise. Vaccine. I guess the question is, will disease or viral mutation or, you know, affect disease development? Question, or or vaccine development. I'm sorry.
So I think the question is your question is, would the mutation in the virus strain will affect vaccine development?
Yes. Time frame.
Okay. Yes. So the good news is that we know there are already various different strains of coronavirus. Last I looked, there were about 8 different strains of COVID-19, but these strains are very similar to each other. So as of now, the vaccine development would cover most of these strains, so we shouldn't have any problem. But if the virus mutate further, which the most likelihood of mutating would be the next season, so which will be the the next winter maybe, which we don't even know whether it's going to be like a flu, whether it comes every year or not. We don't know that. So I'm not trying to say that I know that. But generally, in terms of mutation, whatever mutation we need to see, we have already seen multiple strains. And these multiple strains are close enough that vaccines that are currently in development would be effective. I cannot speak what's going to happen next year. That's where my limitation is. I don't know if that would be a significant mutation. And in that case, we would have to develop a brand new vaccine like what we do for flu or influenza every year.
Sounds good. Thank you. So then there's a couple of practical questions. I would say, let's say that you're living in a home and someone in your home has been diagnosed with COVID. Do you try to you have myositis, your care partner, whomever, or family member or something does not. But let's say at some point, someone in your household is diagnosed with COVID, it's not you. Should you shelter in place, or if you have the resources to go elsewhere, should you try to go elsewhere?
Well, if you have, ideally speaking, because myositis patients are at high risk, if people have resources and money and they can spend a week or two somewhere else, if that's possible, I would say go ahead, do that. But most people are not able to do that. And what I recommend is very simple. If you have 2 rooms in your house, use separate rooms for sleeping and all the activities that you do during the day. Make sure your utensils, you're not sharing things, maintain social distancing in your home, wear masks in your home. And if you do all those things, I think you can limit the risk. You're still at a high risk, but overall you can significantly limit the risk. Frequent hand washing, face mask, social distancing, keeping everything separate, your room separate, your things separate, your utensils, everything separate would be very helpful.
How long?
So generally what we say is 2 weeks, but I would say, and I've seen some examples where people have used a 3-week threshold or even 4-week threshold just to make sure that people are still not shedding virus. Because even when people get infected and they get better, it takes time before their body can clear all the virus. So the shedding can continue even after the infection, even after the patient is recovered. So I think give or take, I would say 3 to 4 weeks would be adequate.
Okay. Travel. I guess my wife had a question about travel. If you had to travel somewhere, you're a myositis patient, you do not have COVID, you have to travel if it's domestic, obviously. Let's say you're going to be, it's a drive versus a fly. Do you have any general thoughts on the matter?
Drive.
I do get this one a lot. Like, really from friends and everybody. I mean, this isn't a 2-hour. This is it's a 12-hour. If it's 4 hours, you drive. It's not New York to San Francisco. I mean, it's a. Go ahead.
Drive, and also drive not only with the essential family member, means whosoever needs to go should go. Not everyone should go. It's not like if you have to go see your uncle and you take your kids and everybody along. It's not like that. If you have a business to do, take care of someone, go drive, take care of it and come back. The flight would be of high risk, mainly because you're going into more public areas. Mainly is the airport that you're worried, because all different people are going to come in airport at different time points. Flight, you're going to be in a more close spaces with various different people. So definitely, hands down, driving is far more superior. But if you have to take a bus or public transport for any in that case, then I think it might be equivocal. But private cars are far safer than otherwise. If you're going to airport or public transport or flights, wear mask and hand washing would be my recommendations.
Okay, great. Couple, as far as getting to the questions, I think if they're about a specific, case, your case, it's hard to discuss those in this format. Okay, I'll try to pull principles from that. And I would say I deal with this, which is, for people, who are at risk like us at this point, what's your recommendation about routine care? You know, there's a mole. I'm not lying to you. My wife's been bugging me about, you know, and I've been ignoring it. And then of course now you know, it's getting darker. And so I need to, you know, at some point, do I need to go in and have it checked? Routine, you know, dental care, which is a challenge. Don't get me wrong. Dental care, the aerosolization of the things, physical therapy. We struggle with this too. Trust me. Medical director for an orthopedic, part of big orthopedic practice. And you try to, you know, a month ago, what was essential at that point, if you broke something, you know, you couldn't walk, we would see it. But we're now 5 weeks into this, to be honest with you, stuff that you've kind of put off stuff. And we struggle now in Illinois. They're allowing us to start do some elective surgeries carefully, you know, and not bunions or hammer toes, but something if somebody's got a locked meniscus and they can't walk. So the hard part is how do you know, there's no right or wrong answer. There's no, but how do you think about it? So PT, routine care.
I mean, I think it's very difficult question to be honest to answer on general terms, but it all depends on what is the problem and what's the level of problem or disability that you're having with that problem. You know, first we said no elective surgeries and only emergency surgeries and procedures. Now we are moving to saying, okay, you know, necessary treatment still can be done. And in subsequent weeks to months, I think we're going to go into more urgent, but not, you know, routine care. And then eventually we're going to go into more routine care. And then eventually the dental care and other care is going to come in. It's tough to answer that questions in particular, because what's happening is people are saying, I have my kid whose eyesight needs to be testing. And every day he tells me my eyes are poking and he's miserable, his eyes are watering, but I have nothing, I can't do anything because I can't take him to an ophthalmologist because it's considered routine care. I think in future, at least what I can say we are doing in our offices, and I think I hope other doctors do the same, make the decision on case by case basis. Listen to the patient, see what their problem is. If they need to be seen, see them. If it could be done via remotely through telemedicine, because many things can be done through telemedicine. If that can be done through telemedicine, do that. And if that can be done over the phone, do that. But if a patient has a significant problem that needs to be dealt with in the matter of weeks, then please do that. I mean, we are seeing limited face-to-face patients. When we see them, we ask the patient to mask, we mask, we maintain the distance as much as possible. I've even gone to wearing gloves while examining the patient so much. So there are ways you can prevent the risk of infection, but you have to take care of the patients when they need you.
So along those lines, just, you know, a couple more questions as you were pop along the same line. So I think what we're doing is, in general, your own provider will know you the best, okay, or should know you the best. So at the end of the day, you know, is it time, if you're screening blood work, or you know, if it's a follow-up cancer CAT scan, you know, this is one of those, we can't give general advice here over the airwaves, but I think that's one of those, talking to your physicians, trying to get some idea of whether you think it's available. Telemedicine is an option, obviously, for certain things. I would say that at least in our facilities, we're seeing that the fear was, oh, don't go to the ER because you're going to get COVID. Okay, at the end of the day, at least what we've found in our hospitals, that the inter-hospital transmission is really, really, really low, you know, which is so, you know, I was nervous about that, not going to lie to you, 6 weeks ago. I feel much better about that now, that if I needed to, you know, at some point in the places. So I think individualized, you do need to speak to your physician. The good news is they kind of got time right now. I'm not going to lie to you, our clinics are not very busy, so it should be something that you should be able to get into. Last, before we move into the non-COVID stuff, so what's your been experience with, you know, myositis research? Has this kind of brought stuff to a halt? Have you still been able to do stuff, or how has this affected research?
So I would have to confess that one of the worst areas it has really affected is research. We were doing 3 clinical trials. All of them have stopped right now temporarily. We had patients on ongoing protocols. We had to hold off on that. And at the end of the day, it's actually hurting our patients, because those patients are in clinical trial for a particular reason. They want to get better. They want to get an experimental drug to see if they improve or not. So it's significantly affecting the research arena. At least personally, it is affecting my research significantly. The other point I want to make is it's also you know, affecting people who are you know, actually giving funds. because in this crisis time, everybody needs money and funds to be reserved. And so it's actually decreasing people giving overall. So I would appeal to people who are listening to please continue giving because, to Myositis Association and other donations that you make, so that this research can continue in this disease area. I also want to point out Dr. Chris Weil is going to be taking a seminar or a webinar, I think, in next few weeks on this very topic. So if you're interested, please join that webinar to understand what's being done in the research arena to cope with this problem. And personally, I am focusing my research on remote research, basically research through telemedicine. I've been working how I can increase patient participation across the country and perhaps across the world by doing research without having patients to travel to my office, through telemedicine, through getting the local blood draw or transporting the blood to us if needed, using mobile apps and websites. So we've been very successful in that type of research, and I think that type of research needs to be promoted.
That's great. Before we jump off of COVID, I think you answered these, but I think for clarification, because they're important, antibody testing. So I guess the question was going to be, not all antibody tests are the same. And I think we are still learning, okay, what certain antibody tests mean. So I guess in a nutshell, just because you have an antibody test done somewhere that was positive, does it mean that you're immune? And if you could, I know you can't answer, I get that a lot, because there's a lot of tests that are not being regulated by the FDA now, and if they're positive, people just think they're fine. So if you could expound on that a little bit.
So one I would say is if you're doing a testing from a well-known lab, for example, Quest. I mean, I'm not trying to promote Quest or anything, but labs like Quest, or they are going to use FDA-approved kits and so on. So one is do the testing from a reliable source. But the other problem is, even if the testing is done from a reliable source and it's positive, all it means is I was exposed to the virus before and I develop antibody. I may not have infection, but that doesn't mean that you cannot be reinfected, because we don't know that. Right. It's too early to tell that. I mean, I hope that you cannot be reinfected and that the antibodies are actually protective overall. But as of now, I don't have that information currently available.
And last, before we move on, a good question, talking about places, it depends on the state where you live, okay? So how would a myositis patient know when they can trust, that's quoting here, state's recommendations for returning to their normal activities, shopping, meeting. So basically, she was referring to the earlier 40 to 60% of the population has been infected. Yes. Is there another metric, flat hospitalizations, deaths? Don't get me wrong, like in Illinois, we look at, the number of positive cases. Well, obviously there's a huge, as testing expands, that number is going to go up. Right. Yeah. So you look at, a lot of times I just look at, how many are we hospitalizing? What's the rate? Doubling effect. So I guess it's a very good question where if you're in a state, let's say you lived in Georgia, what are the things, I was trying to get it earlier, what are the things that, because we're in a different subgroup. And I think, what are the things that you would look for to help guide those people in states that are relaxing things?
Yeah, so first of all, you need to understand your own risk first. So if you are an elderly patient, if your myositis on immune suppressive drug, or your IBM with significant respiratory muscle weakness, or in general severe weakness, then you're high risk. I would still say stay home till your community or your city reaches a threshold of about 50% of people are infected, because in that case, the risk of infection goes down significantly. Now, once the rules are relaxed, even if you have to go out, still do the three things I talked about. Always wear a mask, always use the hand washing frequently, and maintain social distancing as much as possible. So those are my recommendation. Obviously, it's different by state to state, but again, keeping precautions till your community reaches 50% of infected state would be the best. Now, obviously, what you talked about, rate of death is important, rate of hospitalization is important. Those are all the parameters that you can look for in your own community or city, whether in my community, district, or state, is that going up or not? As long as it's not going up and it's steady, you know that you have flattened the curve overall.
Thank you. All right, I'll give you a break from COVID. You can kind of readjust here. So as far as a couple questions, take a break. Give you a second. Okay, I think as far as a couple non-COVID questions, and then if anybody has, or kind of be wrapping things up here, so if you have any other questions, shoot them my way. I'll try to get to as many as I can. So basically, kind of a random sort of non-COVID question. Are there any studies looking at a recent, basically looking at a recent history of major trauma? We talked about this before, as a trigger for DM or autoimmune disease? I hadn't seen that.
Yeah, so I haven't heard of any major trauma as a trigger of autoimmune disease or myositis in general, but I will share some examples. So I've had patients who actually had a fall for non-myositis reason, and then on the recovery they realize they're not able to get up from a chair, and they realize then, and that led to a diagnosis. Or people who were otherwise healthy, and an event happened, and now they realize that they are weak and led to the diagnosis of myositis. In most of those cases, if you dig deeper, what you realize is the patient probably had symptoms to begin with. They had a subclinical disease. They weren't feeling that much because they were in their routine day-to-day life. But that event of trauma or infection or whatever actually made them worse in their physical ability. And when they're trying to recover, they realize they're not able to recover now because of myositis. So that we see a lot, that the event actually brings their disease to forefront as compared to causing the disease per se, okay? And the second part of what are the other triggers of dermatomyositis or autoimmunity. In previous webinar, we talked in detail, and I would I encourage people who are asking this question is to see that webinar, because the whole webinar was on triggers for or risk factors for autoimmunity and myositis. But couple of them I will mention briefly here. UV light exposure, high UV light exposure could be a trigger. Patients taking different drugs, for example, statin, could be an exposure. Patient getting various different infection could actually trigger the immune system to lead to myositis if you have a genetic makeup already to develop myositis. So those are some of the risk factors. Smoking, sorry, I was going to forget, smoking is a major risk factor for anti-synthesis syndrome in particular. So these are some risk factors I will name briefly, but more detail on these in the webinar that we did last week. And I think it's available on the Myositis Association website.
Thank you. Well, I guess it's somewhat COVID related. I guess in this time of limited access to good food, do you have recommendations? I'm not going to lie to you. I've eaten more Life cereal, stuff I haven't had in a while. Not going to lie to you. I think I even had pizza rolls the other day. I was looking for something to eat. So at the end of the day, I'm proud to say that, by the way. But as far as I mean, it's hard. As far as we can get, it depends where you live. We can get apples. Fresh meat is hit or miss. Veg, some of the stuff it's very hit or miss. So my gut tells me best that you can. You got to get through this, and I don't know. Any thoughts on that?
Yeah. So what we are seeing, at least I can tell you my experience from my patients, is weight gain has been a major issue because of two reasons. One is the food. When you don't have much to do or go out, what you do is keep munching, that's one problem. And the second problem is everybody. And the second problem is you don't have any way to do exercise. Your house is limited. I mean, you might be lucky that you have a, near nice by walk to do, or some kind of equipment in your home, but most patients don't. So they're limited in terms of amount of exercise they can do. So actually it's like a double whammy. One, you are eating too much and not eating healthy at home. And the second is you can't even exercise. So it's actually making a big problem right now when most of the patients are complaining of weight gain. And then what one more thing I want to point out is it does lead to social distancing, and staying at home and lockdown does increase to little bit of depression. And what happens is when there is increase in depression, even a little bit, again, food is what you go for. And that also lead to further weight gain, and that leads to further depression, so it's become a vicious cycle. So it's actually not a perfect situation for us to be. What can we do about it? It's very difficult question. I wish I know the answer. I don't. All I can say is the best way to monitor things is to check your weight regularly, because if you're checking your weight regularly, that will make you more conscious of using, not munching all the time and doing healthy food habits. In terms of the diet, if you could do Mediterranean diet at home or intermittent fasting, or those kind of things have been shown to significant beneficial effect on cardiovascular and other system, would be very helpful. We know that diet does play a role in immune system. We know that from rheumatoid arthritis, omega-3 fatty acid decreases the inflammation in rheumatoid arthritis patients. So we know there is a tight link between the inflammation and diet, but it's tough in this situation to really follow healthy diet, and I understand that. The other point I wanted to make is about the diet in general, is we have a chapter on dietary aspects of myositis in my book, Managing Myositis. So people who are more interested in that particular aspect should read that chapter, which is written exactly keeping this in mind. What are the risks of the food, and what are the benefit of some food possible in myositis?
Sounds great. Thank you. It was a fantastic book. And for those of you I'd recommend it, it's just geared for clinicians, I would say, but there's some still, but listen, I think what I'm finding is, listen, there's most myositis patients, I'm not gonna lie to you, are as well-versed in this as many or most physicians, to be perfectly honest with you. One clarification, then a couple cleanup questions. Clarification about statins and IBM. I think as far as statins, do statins cause IBM? If you could clarify that statement.
No, there's no evidence that statin causes IBM.
Okay, then it did come up, like 5 or 6 of the questions did pop up in general about IBM and treatment of IBM, and this is it's a fairly, I went through the gamut. I was seen by people who said, well, there's nothing you can do, nothing's going to help. It's tough, I'm not going to lie to you. It was, but then as time went on, I'm somebody who does seem to get some benefit from some mild immunosuppressants, high CK levels, etc. But the key, at least what I found, is the exercise. At the end of the day, and I wish I could tell you, I don't know where I would be if I didn't, exercise. I kind of have a clue. And then as you develop the recurve item and the foot drop and stuff, you get the braces and stuff. But in general, could you outline at least your principles of IBM treatment?
Okay. So first of all, if I list the treatment of IBM, the number 1 treatment is exercise. The number 2 treatment is exercise. Number 3 treatment is exercise. Okay. Then once you've gone through, once you've done first, second, and third line treatment, then what I call as a 4th line treatment would be IVIG, because there have been studies where IVIG has helped patients with dysphagia. There have been studies that IVIG anecdotally help patients with IBM. Again, only helps in patients who are rapidly progressing in that case. So IVIG, again, it's a very controversial topic. So I didn't want to comment on it, but I will comment on it as a 4th or a 5th line treatment has been looked into in different studies with mixed results. Okay. And then the 5th would be immune suppression. As you yourself said, I have about 5% patients with IBM on immune suppression. And that's exactly for the reason you said. In those patients, it actually do help. And I will explain you this a little bit, why in some patients immune suppression or IVIG helps, whereas in most patients it doesn't. And the reason for that is many patients, at least in my observation, are sort of not pure IBM. They're IBM and other myositis, inflammatory component mixed. And in those patients, I've seen particularly immune suppression or IVIG, another treatment, actually may be of benefit. We know this also from another fact. When you have IBM and you have another autoimmune disease, typically, for example, Sjogren's syndrome, it has been shown that immune suppression may be more helpful for your disease than as compared to pure IBM patients. So not all IBM are the same. So it again depends on your doctor. Talk to your doctor and see what they recommend for you.
Well, thank you. And just so you know, the exercise component is challenging as an orthopedic surgeon with the disease, at least for IBM. It's something we're working on. I think, there's been some very good work that's been done out there. There's a lot more, and I think the hard part is getting that information out to the physical therapist. So I think at this point, I will wrap up. I want to thank you, Dr. Agarwal, for for taking the time. This is a very informative discussion. I'm sure, unfortunately, I guess it's a good sign when we finish up and we have as many questions as when we start. I want to thank you for taking time out of your day to help our patients, our caregiver. Dr. Agarwal does tremendous amount of work to support TMA through his webinars, videos, blogs, and to keep the TMA community informed, and we truly appreciate it. It's a very good example of collaboration between TMA and the MAB, and we thank you for that. I'd like to highlight unrelated, pass on kudos to Marianne Moyer. I'd like to highlight a tremendous fundraising opportunity that begins tomorrow, and it runs for 24 hours. TMA is participating in the Community Foundation of Sarasota County's Giving Challenge. And what this is a unique opportunity to have your donation to TMA doubled. The Patterson Foundation, God bless them, is doubling all unique donations up to $100 made through the Sarasota County Giving Challenge or through that foundation. This will be running tomorrow for 24 hours, so please consider giving tomorrow. There will be a pop-up box on our website tomorrow with further information on how to donate. And we appreciate it, these challenging times. Thank you. All right, Mayor.
Thank you.
It's all you. Thanks, Dick.
Great. Dr. Mogul and Dr. Agarwal, thank you so much for this really interesting interview and very lively discussion. We are so honored to have you both as leaders of this leading international organization, and thank you for your extraordinary leadership and all that you are doing for TMA and myositis patients and families around the world. Can't thank you enough. Thank you so much for all that you are doing. Next slide, please. So in addition to the virtual, in addition to the giving challenge that, as Dave said, is happening tomorrow and Wednesday, that we are so very excited about, an opportunity to double the donation. Visit TMA's website. You'll see a pop-up box that will bring you to the place to donate. We are very excited about our virtual summit scheduled for May 8th. This is going to be an extraordinary day. As you can see, the lineup of speakers here on a variety of different topics associated with myositis. This is actually based off of Dr. Agarwal's book that we were just talking about, Managing Myositis. We're so honored to have all of these guest speakers who will be doing presentations, but there will also be opportunities for patients and care partners to engage in virtual chat rooms and to visit exhibitors and engage with these exhibitors throughout the day. It starts at 8 a.m. and it ends at 7:30 p.m. But in addition to that, those who register have access to the platform for 30 days. So don't miss this extraordinary opportunity for education as well as for networking with each other on May 8th. And we're really excited to announce that we just have planned a new session on COVID-19. This is going to be a moderated session as part of the virtual conference on research and clinical practices in the COVID era. This is what Dr. Agarwal was referring to during answering one of his questions. But Dr. Weil is going to be, again, facilitating this lively conversation with Dr. Mazen Demachki, Dr. Ricardo Roda, Dr. Farmer from Kezar Biosciences, and representative from Corbus Pharmaceuticals. So we've extended the day, and this is a really exciting new session that we're thrilled to be adding to the virtual summit on May 8th. Next slide, please. Please be sure to continue to check on our COVID-19 clinician and patient web pages that we have developed. We developed these pages to keep you all up to date and informed, and they're filled with videos, blog information, resources, and updates. So please be sure to check frequently. And thank you again, Dr. Agarwal, for all the wonderful patient education videos that you are doing, some of them on COVID-19 and others on myositis topics in general. We can't thank you enough for producing these to help educate the community. We do have a webpage with Dr. Agarwal's videos, so please be sure to join that and see those videos on an ongoing basis as well. Next slide, please. I hope that you all received the announcement that we sent out on Friday. The board of directors made a very difficult decision, but an important one, to cancel this year's Imagine the Future annual patient conference, which was scheduled to take place in September in Bellevue, Washington. Of course, the myositis community's health and safety is of utmost importance, and we want to make sure that you all stay healthy and safe, and that means not traveling to Bellevue, Washington. We are working with the hotel. We hope to have the conference there in 2021 at the same Hyatt Bellevue, and more to follow on that. In addition, we are exploring an opportunity for a virtual event in the fall sometime in lieu of the in-person annual patient conference. And please stay in tune for that, and we will be announcing future announcements about that. Next slide, please. Myositis Awareness Month is coming up, of course, May. Please be sure to check out the Myositis Month. We have a lot of interesting programmatic activities coming up. We, of course, have our awareness toolkit that you can download that can help you engage at the community level. Again, the virtual summit that kicks it off on May 8th. We have really wonderful social media graphics that we are currently designing in final stages, and this is on empowering the patient, effective communication with your myositis provider. Please also join us for upcoming webinars. May 14th, Dr. Tom Lloyd is going to be doing a webinar on communication tool and tips and tricks. And then also we're planning right now a really exciting webinar on telemedicine, how it works, what are the potential benefits and challenges for the myositis community. And then on May 20th, Dr. Agarwal is kind enough to be producing our first Twitter chat. And this is going to be an extraordinary event that's going to be talking about effective communication with your doctor in the digital age. So please mark your calendars for these exciting programmatic activities, and be sure to continue to check out the Myositis Awareness Month page for additional programmatic listings. Next slide, please. And remember to complete your post-webinar evaluation that we'll be sending out by email. It takes just a couple of moments, but we really do pay attention to your feedback, and it helps in planning future webinars. By the way, all webinars are recorded and are hosted in our library section of our website. So please view that. And I know Dr. Agarwal's was highlighting the one we did last week. It was an extraordinary webinar. I encourage you all to look at it in terms of triggers and myositis. And if you're not a member yet of TMA, please join to be sure to stay up to date on the latest events. You can do that on our homepage. So I want to thank you all very much, and we really appreciate you being with us today. And again, this is recorded, and if you'd like to hear it again, visit our webinar page. And thank you so much, and continue to be safe and healthy. Thank you.
Thank you.